Good morning, good afternoon, everybody, or good evening, wherever you are. We are we have our monthly PACE meeting conference and our webinar today. Just to start with the ground rules of the PACE. So PACE is a patient and caregiver engagement group from GlamCon, and only patients and caregivers are allowed to participate in this meeting. This event is not to obtain, solicit, or share medical advice, but serve only for educational purposes. This event does not and cannot relate to the care provided by the kidney doctors. And for your own individual health or kidney related questions, please speak directly with your doctor. With those ground rules, I'll just introduce myself. So I'm Dr. Tripti Singh. I'm one of the nephrologists at University of Wisconsin-Madison. I take care of people who have kidney diseases, especially glomerular diseases, and kind of co-run this PACE group with GlamCon with my partner, Tony, I'll let her introduce herself now.
Oh, hey guys, I'm Tony. I'm just part of the GlomCon PACE, patient and caregiver engagement. So I'm here to what do you say, raise awareness and educate people as much as we can. So it's good to be here.
And then we also have Rika here, who kind of helps us with the admin support, whatever we need with this. With that, today we do a kind of a small presentation on a topic. We kind of talk about a specific topic and go over it. Today we decided not to do that and just kind of take the questions or the most commonly asked questions that people have. And then we'll just go back in question format back and forth. If you have any questions come up, feel free to put them in the chat, and we'll get to them in between as they come in as well. Okay. Tony, do you want to just start with the questions and
Oh, okay. So let me just go ahead and start with the questions. There's several of them that came from Facebook. So the first one was, I have FSGS and I'm on 2 water pills and still very swollen. Any tips on how to get some of this water off?
Yeah, this is a great question.
Mm-hmm.
So when you have FSGS or when somebody has FSGS, what the problem, and I think I'll take it stepwise because I think understanding why you're having swelling also really helps in kind of managing swelling, because then you can work in different ways to get rid of that swelling. So then when you have FSGS or somebody has FSGS, they have kind of some damage in the cells in the kidneys, and that damage in the cells in the kidneys causes more scarring in the kidneys. And the way I like to kind of think or conceptually tell people is that makes tiny, tiny holes, and it's not like really holes, but those damage causes scarring. And because of those tiny, tiny holes, a lot of protein, which should stay back in the blood, kind of leaks into the urine. And so you get those foamy urine and a lot of protein leaking in the urine. So as a normal kidney would do, or a normal organ in a body does, it kind of tries to keep that protein back and reabsorb that protein. In doing that, as hard as it tries, it also starts reabsorbing the sodium back. So it retains that sodium, and it's with the sodium in our body, wherever that sodium goes the water, and it's that sodium and water that causes the swelling in your legs or all over the body. So the 2 water pills that somebody takes, or the water pills that we use to get rid of the swelling, makes the kidney get rid of that sodium essentially, or not reabsorb the sodium. So you get rid of that sodium in the urine. And again, if the sodium goes in the urine, the water will go in the urine as well, and you get rid of it. So as you can imagine, because you're retaining that, it's the sodium, one of the ways is if you put less sodium in your body, you'll have less swelling. So following a low sodium diet and eating less sodium will decrease the swelling. The water pills actually don't work really well if you're not on a low sodium diet. And when I say a low sodium diet, that probably is about 2 grams of sodium, or 2 grams of salt or sodium. When you look at the product labels, it comes as sodium. That's that. If you're eating less sodium, you're going to be less thirsty and you're going to be drinking less. So you don't even have to follow that much on the fluids. It's the sodium that I would say is more important. and then restricting a little bit of the fluids with it. And then you will continue to have swelling until your treatment for FSGS works and until that protein in the urine can go down, because it's really impossible to lose all of that swelling until you're losing tons of protein in the urine. And sometimes the medications that are used to get to decrease or treat FSGS are steroids or prednisone. And one of the side effects of them is also retaining salt and water, and that makes it harder. So I know it was a long long answer, but just summarizing back, ways you can help decrease the swelling a little bit more is limiting the salt in your diet. That really goes a long way in low sodium diet, keeping the two water pills that you have, and then until you get into kind of remission or at least decrease protein in the urine by whatever treatment you're going for FSGS, that swelling will kind of remain. They sometimes, we as nephrologists, your kidney doctor might add a third pill or might do IV if the orals are not working. If it is really, really uncomfortable swelling and it's really impossible to even eat and you get swelling in your belly or legs, so sometimes that might be needed as well.
Right, right. Okay, so the second Facebook question was, when someone with primary FSGS has relapse, first time following prednisone, at what point should medical intervention begin to reduce proteinuria? What course of treatment would be likely if prednisone was not tolerated well by the patient?
Yeah, again, this is a great question. I think for FSGS, when what the guidelines and when we treat somebody with FSGS, the first is the prednisone, and as this person had, which has a lot of side effects from prednisone. Usually, when we do prednisone, we do want at least 4 months of prednisone before we say you're not responding. But if you had to stop before that and you relapse, it's still responsive. We won't say it's still responsive to prednisone or could be responsive to prednisone, which is a good marker. And if somebody cannot tolerate prednisone, then the first line drug that we use is called as calcineurin inhibitors or CNIs. And one of the most commonly used among that class of drugs is called as tacrolimus. And that's what the most common first line after prednisone is recommended is using calcineurin inhibitors, which is tacrolimus.
Okay, so which goes to another Facebook
Mhm.
question about tacrolimus is at what point does a nephrologist consider switching from tacrolimus to Cellcept? And then that person's understanding is that Cellcept is not as nephrotoxic like tacrolimus can be.
Yeah, that's a good question too. So tacrolimus, if you are in remission, again,
Mhm.
we really don't know. The guidelines are not that clear as to how long to keep, but usually we would like to not start tapering before 2 to 3 years of remission. When we talk about nephrotoxicity from tacrolimus, the two things to consider. One, that toxicity takes about not like 7 to 10 years before we think it is meaningful. So usually 3 years, I wouldn't think or I wouldn't consider having nephrotoxicity from tacrolimus even an issue. But beyond 5 years is when I would start at least thinking about it and thinking about considering changing if needed, or if somebody been in remission really well. But the first thing at that time would be considering, and per the guidelines, to be tapering off the tacrolimus. Because if somebody's been in remission for this long, it is recommended to probably get somebody off the medication and see if they might not even need another medication. Again, Cellcept has not been studied so well in FSGS. There's a lack of studies in FSGS, again, because FSGS is a very varied disease, and we put a lot of diseases which might have different pathogenesis or why they happen together. So it's really hard to study in studies, clinical studies. So Cellcept has not been very well studied. But again, saying that, a lot of kidney doctors use Cellcept because Cellcept works really well in a lot of other kidney diseases, and we kind of extrapolate. So would I would I consider it after tacrolimus if somebody's been on tacrolimus for some time? Probably that would be my maybe second or third line medication. Again, this is goes again by kidney doctor to kidney doctor we're using, because there's not a lot of studies and not a lot of data, and the guidelines actually don't say anything specific. I don't know if that answers the specific question, but I would say the other point that I really want to make sure that tapering off tacrolimus, if somebody gets a flare, that would be more harmful to the kidney and might cause more damage to the kidney than actually the nephrotoxicity from the tacrolimus over 3 to 5 years, because every flare you get, it causes more damage to the kidney and might cause more scarring because it takes a little while to get into remission. So you really have to weigh the two benefits or risk of having a flare by tapering
Hmm.
off tacrolimus really soon and going on Cellcept versus keeping it, because any flare will decrease the kidney life a lot as well.
Yeah, that's a good point. That's a good point. Okay, and here's another Facebook question. It says, what can patients do to make the best use of their time with their doctor at their appointment, from a nephrologist point of view, to maximize the visit and be prepared?
Yeah, that's a very good question. And Tony, you might probably chime in this one too, but I
Hmm.
can tell it from my perspective. I think one of the things, probably to when I think or when I tell my patients, when I see there is a lot of things that go on and it's really hard. I really want to make sure that my that the patients understand why they have what disease they have, first of all, because sometimes we talk so much and not talk like what the name of the disease is, because when you're looking it up later,
Hmm.
and I encourage my patients to look up, and you should, because that's how you advocate for yourself, is knowing what the name of the disease is exactly. The second thing is what do we track, or how do you know that I'm doing, like, what is wrong and how do you track improvement, right? Because that's when you would know that this is working or not, or how do you know it's getting better. And then the third, when they start talking about medications, is like, um, again, how do they work, which is the first we talked about, but again, focusing also on at least known side effects of the medications and asking those, both short term and long term. And this is a whole long list, and you might not be able to get to all of them on the first visit, and you can just keep building on that as well on the subsequent visits as well. And then the fourth is, especially with glomerular diseases, sometimes it is kind of what to expect in future, like how long these medications
Hmm.
would be as well, because that becomes really important. Some of them are possibly lifelong medications, some of them are for shorter duration. So those are a lot of changing things as well. And then as you understand the disease more, then you know about relapses and remission and how the disease progression would be as time goes on. And so those are the kind of things that I focus on when I talk to my patients. At least they understand how do we track the disease, and then what to over the next subsequent appointments, what to expect in future for them to plan their life, right? And kind of know what would come. At least the best I could tell them. Sometimes it's not how it goes, because it can be very different and we can't predict the future, but at least the best I can tell them. I don't know, Tony,
Right.
do you have any more tips and suggestions for people kind of before they go to visit a doctor?
I would say just, bring in your list of questions that you have, anything that concerns you. Because some people just tend to forget when they get into the office, they just forget what they're going to ask. So I think the most important thing is maybe to write it down.
Mm-hmm.
Um, so you just don't forget,
Yeah.
and then you could
Yeah.
always contact the doctor too if you forget. You could
Yeah.
always message them later.
Mm-hmm.
And then, ask them questions.
Mm-hmm.
Yeah.
Yeah.
So, okay. So there's more questions here that I have. So here's one of them. It says, well, we've done proteinuria before, but here's another
Mm-hmm.
question. What is proteinuria? We see this a lot in kidney disease.
Yeah, that's again one of those that the question that you go the first question to ask, because what actually is proteinuria? So proteinuria essentially means having protein in the urine.
Hmm.
That protein that we check is primarily a protein called albumin. And one of the most common questions that I get asked from my patients is it because I'm eating a lot of protein? Is that the protein coming out in the urine? And it's not that protein coming out in the urine that you eat. When we eat the protein, it gets digested, it gets broken into amino acids, and then our liver makes more protein, a different type of protein in our body that's called as albumin, which is in the blood. It all also makes a lot of different type of proteins, which different like your muscles need or all the different parts of the body need. But the one that we are talking about there is in the blood called as albumin. And so that's the protein that leaks into the urine, that albumin, and we call it as albuminuria or proteinuria. Higher that protein in the urine is, worse the kidney disease essentially. It means that you're leaking more protein, you have more holes in the urine. But it also, the higher that protein in the urine, more damage can happen over time to the kidneys. And that's why it's really important, because over time it will cause damage to the urine. When somebody has protein in the urine, they're getting rid of the toxins really well. And it's still not what we call as kidney damage as yet. But if it stays like that, it will lead to damage of the kidney and building up the toxins. And you need somebody needing what we worry about is essentially dialysis after a while, because it will cause damage to the kidney. So that's essentially what proteinuria is. I think with that comes how do we measure proteinuria? And usually most of the people have that question when we think about what is proteinuria. So we check for protein in the urine, but we check for protein, that's one number if you have a single sample of the urine, but we also check for creatinine in the urine, because that protein in the urine varies minute to minute. So it's not like you can check one sample and get the whole 24-hour. So one of the ways is that you can collect all the 24-hour urine, and a lot of people would have done it, those who have kidney disease, or their kidney doctor might have asked them to do that 24-hour urine in a jug. It's very cumbersome. It's not easy to do. So we don't do that a lot, but that's one way of knowing how much protein you are spilling in a day. The other way is you just pee in a cup, and we check the urine protein and you check urine creatinine, and we do a ratio of those two numbers. So we divide urine protein divided by urine creatinine, and you get a number, and the number that you get is equivalent to that 24-hour protein that you would spill in the urine. And that's one of the urine tests that's ordered by your kidney doctor, probably every time you go see them before that. And so that's one of the numbers that we track as to how good your kidneys are doing. And usually there should be zero protein in the urine and zero albumin in the urine. And that's what we aim for, because the kidneys should not lose any albumin or protein in the urine.
Okay, so pretty much like if somebody says they don't have diabetes, they don't have high blood pressure, those are the common cause of kidney disease. So how did that person get kidney disease?
Yeah, again, that's one of the questions that come up. So the kidney
Mm-hmm.
diseases, again, the two most common cause of kidney disease are diabetes and hypertension that we know of. But there are a lot of other causes of kidney diseases as well. And some of them are autoimmune, where sometimes our own immune system starts attacking our own kidneys. Sometimes there are genetic disorders that can cause kidney diseases. Sometimes there are some heavy metals or intoxications or something else that can cause kidney disease. And so it would be a thorough evaluation that you would need what's causing the kidney disease. Again, somebody who has diabetes and kidney disease, it's not necessarily that always diabetes causes kidney disease in those people. They could have an autoimmune disease as well. And that's what your kidney doctor will try to figure out as to why you have kidney disease at that time. So again, they would order a lot of tests, and sometimes doing a kidney biopsy helps in knowing which type of kidney disease is and possibly what's causing that kidney disease as well.
Right. So maybe they might order a genetic testing too. They can't
Yeah,
figure out the cause of that, right?
exactly. Yep,
Okay.
definitely.
So if the kidney doctor orders 10 blood tests every visit,
Hmm.
okay, which one should they look out for? Which one
Yeah,
should they pay attention to?
yeah. And this is again one of those questions that I also get asked by my patients a lot in the visit, because they like usually I would order the blood test before they come and see, and they'll get drawn 5 to 7 tubes and 10 tests, and they're like, Doc, these are way too many, and what should I look at? So I
Mhm.
usually tell them the most important tests for somebody to look is called as creatinine. That's your kidney function. That's actually the number that tells us how much your kidneys are working. With that creatinine comes an EGFR, or estimated filtration rate, glomerular filtration rate. That's the GFR. And that gives a number as to, let's say, 100 mLs per minute. And that's the amount of blood that your kidneys are filtering per minute. It varies by age, and so we look at for your age what it should be, and your kidney doctor will tell you based on that how much percent of your kidneys are working. So they're working 50%, they're working 60%, and that's where you get to know your chronic kidney disease staging as well. And so that's one of the numbers that's really important to look at is creatinine and EGFR, estimated EGFR, which is just calculated from that creatinine number. The second test to look at is urine, protein over creatinine. Those two tests are the most important test I usually tell people when you have kidney disease, and that's the amount of protein that you have in the urine. There's a lot of other tests that are done. Some of them are to track for kind of the complications of kidney disease. Some are for tracking if you have some other autoimmune disease. A lot of others are just your kidney doctor trying to keep you healthy and looking for anticipated complications that would be happening. But the two tests, creatinine and urine protein to creatinine ratio or protein in the urine, are the two most important tests that I think everyone who's seeing a kidney doctor should know what they are and should kind of look for as well. And the rest, I think you can just learn over the time as you go, and your kidney doctor will tell you more about that.
Right. Okay. Let's see. So it says right here, I have kidney disease and will need a kidney transplant in the near future. Will my kidney disease come back in a transplanted kidney?
Again, one of the common questions, I think if you have kidney disease that has progressed on to stage 4 or 5, that's when you would have been referred to transplant. And you will see the transplant doctors. Usually, I tell some of the kidney diseases do recur in the transplanted, can recur in the transplanted kidney and could come back. Because some of those kidney diseases happen from who has the kidney disease from their blood or their body. And because it remains the same, they can come back in the transplanted kidney. Some don't come back. So I think it depends on which kidney disease you have. That's something I think you should discuss with your kidney doctor as well as the transplant doctor when you see your transplant nephrologist, when you see them after transplant. That are you monitoring me for my disease, which caused my kidney failure and can come back? Definitely it can happen and should be monitored and kind of treated as well as going forward. So.
Right. So some people have a genetic
Mhm.
um, uh, kidney disease,
Mhm.
for example, like with FSGS. And some say that when they get a transplant, there is no reoccurrence. But
Mhm.
that's also, I heard that it's not true. So what's the answer for that? Is it true? Is it not true? You
Yeah,
know,
again, it is very tricky because when we say so, some of the genetic diseases, FSGS is one of those where there are some genetic causes. There are other
mhm,
genetic diseases like Alport's and thin basement and membrane and some other syndromes that can cause genetic diseases, which can cause to kidney failure.
yeah,
Um, most of them, if we truly know, they're just truly for sure, like polycystic kidney disease, Alport, and some forms of FSGS. If they're primarily just that, then they don't come back because then you're getting a new kidney which does not have that same mutation, and so they did not.
right,
FSGS, again, like as previously mentioned, is that one of those where there are not one disease. It's a disease which is cumulative together. And so there's not just sometimes we find a mutation that can cause FSGS, but you could have, again, some other things, an autoimmune process going on, or that mutation can trigger an autoimmune process in your body later on. And so that can stay, you still are then develop that your immune body or immune response develops against the kidney or whatever mutation, something in the kidney. And so some of those FSGS can recur, but usually genetic diseases tend not to recur, is what I would say after transplant. But again, nothing in human body is 100%, as then
right.
medicine is 100%, but we worry less about it, is what I would say.
Yeah. Yeah. Okay. So let's just say somebody says, I have kidney disease. Should the family members get tested as well? Does it run in families?
Again, a good question. So some of the kidney diseases do run in families,
Mhm.
and some of them are what we call as monogenic, meaning you find one mutation that causes kidney disease, and the most
Mhm.
common among that is called as polycystic kidney disease. And usually that would be something that you discuss with your kidney doctor. I would recommend if you have polycystic kidney disease, meeting a genetic counselor before you have your whole family screened for that. And it's something very specialized, so it is recommended to see a genetic counselor. But kidney diseases, other kidney diseases, autoimmune diseases, kidney disease from diabetes and hypertension tend to cluster in the family, but it's not one mutation that we know that causes it. And it is not something that we can test and say that you have because of this, and your family member, if has the same mutation, would have it. So for majority of the kidney diseases, unfortunately, there isn't a specific mutation that is there that we can find or have family members tested, um, to be honest. So usually it is not recommended for family members to be tested for them unless they're very specific diseases.
Right. Okay. Okay. So this is more towards the diet and nutrition.
Hmm.
There's one right here. It says, my kidney doctor told me that changes in diet are important in managing kidney disease. What type of changes should I make in the diet? We're talking about sodium, everything. What changes is important?
Yeah. So diet does play a really important role in managing your kidney disease, and it is really important. And that's one of the things that I discuss with my patients the first time I see them and every time I see them, because it is
Mhm.
really important. Because what you put in your body, the kidneys have to get rid of it because that's the job of the kidneys. So by limiting what you put, you make it easier on the kidneys, essentially, is the best way I could put it. So you do help the kidneys in that way, and that increases the longevity or the life of your kidney that it would be. If again, one thing that the starting with one thing, if you have to help your kidneys to limit in their diet, would be again sodium or salt. If one thing that you have to focus on, and which would mean that keeping your sodium intake or salt intake about 2,000 milligrams or 2 grams in that range. And it is really, really important, and small kind of steps in making that happen go a long way, because it's really hard, and that's one of the things that limiting the sodium is really hard, because everything what we eat and everything around us has a lot of sodium added. Also because we as humans are geared to love sodium because we need sodium. It's not that we don't
Mhm.
need sodium, but now we eat too much of it. And if you have normal kidneys, yes, our kidneys can get rid of that excess sodium that we eat. But if you don't have normal kidneys, that stays in our body, and our kidneys have to work harder to get rid of it. So if one thing, that would be the sodium. The
Mhm.
next thing I would say, it's totally worthwhile to meet a renal dietitian. So a dietitian who's specific in the kidney, and it's really worthwhile to spend at least one visit with them, but finding the right renal dietitian, so not any specific dietitian, and to discuss with them, because that renal dietitian should talk to your kidney doctor, and they should have a talk within them as to what limitations in your diet you would have, because not every person with kidney disease need to limit everything other than the sodium, which everyone should limit. And it depends on how advanced your kidney disease is. That's when you would limit. And so not everybody needs to limit what when we say potassium, phosphorus, proteins, and it depends on which type of kidney disease you have and which stage of kidney disease you have. So sometimes it's really hard to do that yourself, and that's where the renal dietitian comes in. Again, your kidney doctor also have like 10 other things to discuss with you, the treatment and how to keep healthy, and might not have enough time to focus in detail about the kidneys. And that's where the role of dietitian comes in as well, of the renal dietitian.
Right. Because there are some people that say, okay, they have kidney disease and they have to stop eating bananas
Hmm.
because they have to watch the potassium and the phosphorus. Um, or actually the potassium. And I think when
Hmm.
it comes to dialysis, they have to watch the potassium and the phosphorus, right? So
Yeah.
it depends on what stage they are in their
Yes.
journey.
Yes, and what their blood test shows. Some of my patients have even stage 5 or have
Right.
on a dialysis and do not struggle with potassium. Maybe it's
Oh,
just the way their kidneys are. It's just what their baseline diet is because we tend to eat what we tend to eat the same things every day, all of us. And
mhm.
so they might not eat food that's high in potassium, or maybe their kidneys are able to handle the load of the potassium. So that's where I was saying it does become important to discuss with your nephrologist the blood test that you have. And it's not that the day you get diagnosed with kidney disease, you cannot eat bananas. Bananas do have a lot of potassium, and if you are able to, kidneys can handle the load of potassium. That's totally okay. It's not like sodium that you would have to limit the potassium. It's actually beneficial, or it's good for you to have high potassium food because that's fruits and vegetables. So that's one other thing that comes in that in kidney disease, the one of the other things that has been studied is eating more fruits and vegetables helps the kidneys actually and keeps you healthy as well, both the heart and the kidneys. And but it's that balancing as if your kidneys can handle the load of potassium. And that's where the blood testing comes in.
Right. So same thing with chocolate too, because that one's high in phosphorus,
Yes.
right?
Yeah, that's the second most common question that people ask
Mm-hmm.
in my clinic as well. Can I eat chocolates? Because it's also one of those listed. Again, we all like to, most of us like chocolate, and usually I tell my patients if they all have normal phosphorus, eating everything in moderation is good. And if it makes you happy, yes, eat it, but not every day, right? Because it's one of those. It's keep it as a treat, which is supposed to be once in a while.
Right, right. Okay. So another question would is I'm not a water person. How much water should I drink in a day?
Yeah, I again also one of those. So usually all of our bodies are amazing, and if you don't are not drinking enough water, your brain has a thirst center. It gets activated, and you will feel thirsty, and you'll drink water. Except as we get older, sometimes that gets a little bit difficult. Usually, I'd say drink to your thirst, and you should be okay. You don't have to push more. To be honest, drink to your thirst, and that should be okay. Sometimes, if your kidney doctor is worried, they would tell you drink more water, and then you should. But
Mhm.
otherwise, drink to your thirst. If you're thirsty, drink water, and that's okay. And then that would be completely okay, unless your doctor has specifically instructed you to drink more.
Okay. And here's another thing it says, right? I am trying to stay healthy. Can I exercise if I have kidney disease, or should I refrain from exercising?
Yeah, and to a simple word answer to that is yes, exercising is really good for your kidneys. So if you are exercising, keep exercising.
Hmm.
Usually we say moderate exercise 5 times a week. That about 45 minutes a day is what is recommended in somebody who has kidney disease. That actually helps their kidneys and keeps their heart healthy as well, and keeps their kidneys healthy as well. Usually, if you have advanced kidney disease or stage 4 or 5, or 3B, kind of more advanced kidney disease, then usually sometimes we would say just intense exercise. And when talking about intense, it's like running a triathlon or like really very intense exercise is what I would tell my patients to actually discuss with me in detail before they would run a triathlon and do like a whole day of running outside of like 4 hours or something. And so those are just those intense exercises. Very few people do it. Those are the only ones that I would have them recommend. But otherwise, totally exercise. That's really good for your kidneys and your body and your heart as well.
Okay. Well, those are all the questions that I have right now.
Perfect. I know they were
So,
great questions.
so okay. So we're doing this pace every second Sunday of every month, right? So I think what the next one's going to be, I'm not going to say it's going to be Father's Day, but it's just
Oh, wow, that
no,
would be
I
awesome.
don't think
From
it's going
Mother's
to.
Day to Father's Day, is it?
I'm not sure.
So the
My
next
my
is June 8th. Probably that's the second Sunday. So
yeah,
not Father's
not
Day.
Father's Day. Okay. So that's the next meeting, you guys. So if you guys what topic are we going to do? Was it going to be
Yeah,
FSGS?
we can do
You
FSGS next Sunday. Yeah.
okay.
Both treatment, we can start with just, yeah, management, treatment, diet,
think
kind of everything. I don't know if it is me or were you cutting off or is it my or yours? Or did you lose me?
I
Oh,
lost you.
you did lose me. Maybe it is mine. Can you hear me now?
Nope, happened.
Oh, can you hear me now? No. Oh. Okay, well, everybody, I know Tony's having some issues, or she's back, might be, but that was all for today. Our next one would be on June 8th, where we'll talk about FSGS, just everything FSGS. Any questions about that? We'll focus on that, but we'll take any questions about any kidney diseases because our goal is to just help provide more education about kidney diseases. We try to tend to take a topic just to focus on that. But like I said, and if you have any other topics that you would talk about or any other questions that you have or any topic that you want us to focus on, put that in the chat as well, because it helps us to kind of go from there. And I think that is it. Then we do also have a web page where you can submit your questions. We'll put it in the chat at the end of the in the chat, the link for a web page as well. You can submit questions over there. We'll try to get to the answers of that, and we'll both in writing as well as we can discuss those questions over here as well on the next month from now. And everybody have a happy Mother's Day.